Hello, Dr. Sarah.
Yeah, good evening.
Good evening. Good evening.
Good evening.
He can just try her slides.
Yeah, Sarah, you can just.
Right. She made it in a short notice. I'm very glad.
Yes, she took it also. That is important.
Important.
And she is a first year PGT student, but very courageous. I was thinking she was
Okay.
making a presentation and I found she was making a very good presentation. So many people declined last moment because it was I have never went through these things. I have never seen this, any of the DIP. I know it's going on for last 2 years nearly. So my understanding was wrong. I thought that it will be a case presentation.
Yeah, by the faculty.
Anyway.
Put it on slideshow. Make it on slideshow.
Yes.
Okay. So she's first year PG, huh? Okay.
Yes. So we'll start sharp at 9 o'clock, correct?
Yeah. Just a couple of people will be joining. Yeah, we'll just.
It is like how this goes. Let me just understand the whole.
Yeah. It is like a PG case, madam. Other panelists, everyone can ask, interrupt the student, start right from the history part. Chief complaints, history, approach, differentials, what they considered. Mostly, we want it to be clinically oriented in how they approach a case.
Yes. Yeah. And then who all are the audiences?
That will be postgraduate students, no, across the country.
Across the country. So they get the link from the link which you had shared me.
The mail goes to them from Central IAP. They get a mail.
Okay.
The students had to register, and then we put it on various groups also. So.
So how is the frequency? How frequently? What is the frequency of this?
Every Wednesday, madam. Every Wednesday, and second and fourth Fridays also. Okay. There are a lot of activities now, no? Online activities, lots of them.
Yes. So many of those have started. What has started has not stopped. That's a good thing.
Yeah, it's going on.
And roughly how many students attend?
Yeah, I know. Recently, we've not got. Initially, it used to be around 150. So I don't know now because they were not getting the mails and all that. I haven't taken a call on recently how many are there.
Okay. So the panelist will join here.
Yes. This is the panelist. For the viewers, there is a separate link. Yes, so we can't interact with the students. That's the only problem. We can't interact directly with the students. So unless they put some question on the chat box.
Okay.
Subramania sir, have you joined?
Yeah, I have joined.
Yes, sir.
Ma'am, am I audible?
Yes.
Audible.
Yeah, you're audible.
Okay. Good evening, sir.
Good evening. Good evening. Wait.
Good evening, Sarah.
We will
Good
tell you.
evening,
You can stop sharing the slide. Sarah, you can stop sharing the slide now.
Good evening, Upendra. Good evening, Upendra. Good
He's
evening,
unmuted.
Ramkrishna sir, Sarah madam. I think
Good
he's
evening.
joining.
Good evening, sir.
Yeah. Sarah, you stop sharing your screen. Yeah.
Sarah, you have the name of madam, so see that
Yes.
you will overtake her in life.
No,
You will overtake madam in life. That is the day she will feel a
sir,
lot proud of
that's
you.
a very common name. That's a very common name.
No,
nowadays.
that's okay. But
Exactly.
if she overtakes you, don't you think so? You will feel proud of her in future.
Yeah.
Good evening,
When the
Dr.
students
Upendra.
go,
Good evening.
Good
when
evening,
they
sir.
go
Good
above the
evening,
level of
everybody.
teachers, that's when
Good evening,
we feel
Subramanya.
very much
Good evening.
satisfied.
Sarah
Good
ma'am,
evening, good evening.
Dr.
Good evening,
Dhananjay
sir.
madam, and another Sarah Junior.
Good evening.
Mm.
So today you will have cakewalk with that Sarah madam. She's a tough examiner. Today you will have
So I won't
cakewalk.
be asking any questions to my namesake. Huh?
Madam, no, it is called as conflict of interest.
Ah, yes.
I'm giving you the correct word.
You said it. 1 minute left.
Manjari madam, namaste, welcome.
Namaste, namaste. Thank you so much. Good to meet you.
Yeah,
See
ma'am,
you.
so nice. Yeah, we have met
Yes.
and now we are meeting again.
That Subramanya is Bengal's connection. Durgapur
Yeah,
connection.
yeah.
Yeah.
Understand?
Yes.
Dr. Upendra, shall we start?
Yeah, start.
Dr.
I
Upendra,
think 9
shall we start?
I think his connection is little.
Good.
Yes, can we start?
Shall we
Yeah,
start?
yes, sir.
Okay.
Yeah,
Okay.
please.
Hello.
Yes. Now you are
Yes,
audible.
ma'am.
Now you are audible. It is 9 o'clock.
Yeah.
Yeah, we can
Yes.
start.
So, ma'am, I'll start sharing the screen.
Subramanya.
No,
So,
no, wait,
good
wait,
evening,
wait.
Please
everybody.
wait.
Wait. We will tell you.
Okay.
Yes, sir. Meanwhile, you start.
Yeah, good evening, everybody. So, this is Dr. Upendra Kinzavadekar, President of Indian Academy of Pediatrics, along with my colleagues, Dr. Subramanya sir, Dr. Sarah Danavade, Dr. Ramkrishna Paramahansa sir. We all welcome you to yet another episode of PG Reach, Diamond Jubilee program that we had started from 1st of January. And today, most of us are in West Bengal. So, I am myself
You are
just
everywhere.
entering Howrah. And
You are everywhere.
Oh, good.
Yeah.
Good, good.
So I'm just entering Howrah. So majority are from West Bengal Institute of Child Health, Dr. Manjari, Dr. Sarah.
Yes.
Yes. So I'm very happy to be part of this wonderful program. And today we are going to have the uncommon presentation or common presentation of an uncommon disease. And I'm sure you know that it's the approach that matters, may not be the final diagnosis, may not be when you're presenting the case, but how you methodically approach the case that matters. And I'm sure you will be
Welcome, Dr. Bala, sir.
Good evening, sir.
Good evening. Good
Good
evening.
evening, sir.
Good evening.
Tata Nagar to Howrah. So
Good evening,
thank you so much.
Professor.
And please
Good
keep
evening.
joining. Yes. Yeah. Thank you. Thank
Yeah.
you so
Good
much,
evening.
everybody.
Right, sir. Thank you, Dr. Upendra Kunjavadekar, sir. Thanks for giving the opening remarks. It is inspiring. Dr. Subramanya.
Respected Dr. Upendra, Dr. Ramkrishna, the DO Saras, and then Mitra ma'am, Balasubramaniam sir, Srinivasan sir, who is likely to join in a couple of minutes perhaps, and many more teachers and our dear students of IAP. Now it gives me great pleasure because the theme of today is very nice. It's not about common versus uncommon. It's about presentation versus your probability of being correct. So you might have done a lot of brainstorm. Let me tell you, diagnosis is always an illusion. And a person who is making diagnosis will always feel that he is correct. He is proved otherwise when the case goes to either referred consultant or the patients take second opinion or many times, or when he comes back to you for a revised revisit diagnosis at times. We may prove that the first couple of days we were wrong, and on third and fourth day, it keeps reaching. So diagnosis is a dynamic process rather than a constant thing to be kept in mind. So therefore, that habit of known case of something should be taken off from our mind. I only request and plead on the postgraduates are watching, please think in the following order. I'll go very slow. First, think of common manifestation of a common disease, because the disease is common and the common manifestations of which is expected from you. This is exactly what is at undergraduate level. For them, cough, cold, fever is pneumonia, nothing else. So this is pretty simple. And you can't think of malaria without a fever, for example, for an undergraduate level. This is level 1. Level 2 is, for example, for a postgraduate, he should be able to think of a common manifestation, uncommon manifestation of a common disease. It's very important. That means you should know more about a common disease. For example, if I were to take the first scenario, it's like a fever and a cough in tuberculosis, which is common manifestation of a common disease. If I were to take a rare manifestation of a common disease, it can be hemoptysis in children, in a child with tuberculosis, is definitely something like rare manifestation of yet a common disease. So common diseases do exist, and you can once in a while have a rare manifestation. This should be the second line of thinking. The third line of thinking is common manifestation of a rare disease. For example, same hemoptysis from a patient with hemosidrosis. The disease is rare, but hemoptysis is a common manifestation of the same disease. This should be the third line of thinking. And the last line of thinking, which you should never think, is rare manifestation of a rare disease. And I'm not going to give any example simply because don't think of it. And those are the things that will be reported in journals. So it is for, not for a common pediatrician like any one of us to think of them. But remember, they do exist and they are reportable. And that's how the expansion of the previous 3 layers happen. As and when more and more information pours in, the manifestations become common, which we thought initially to be uncommon can become common later on. These are only 4 or 5 lines from me as an introductory remark, only to see that the postgraduates who attend this session will have something in their mind before they would attend to this theme, which is an excellent theme to start with from Dr. Sara Yasmin and ably guided by Dr. Manjari Mitra. Now, for this type of case discussion, it is our pleasure that we have got stalwarts like Srinivasan and Balasubramaniam sir to be there along with Ramkrishna and Sara. And we will have a wonderful academic feast today. And all the best and wishes, Dr. Yasmin, gold
Thank
medal
you,
in
sir.
advance, and you can start off after Dr. Ramkrishna sir permits you.
Not that way, sir. Dr. Sara, ma'am,
Shall I
can
just
you just introduce
madam?
our
Yeah.
mentor,
I'll just introduce
Professor
Dr.
Manjari?
Manjuri. Yeah. Dr. Manjuri is, I will just give a brief introduction of madam. She's Professor of Pediatrics in ICH, Kolkata, Research Director for Mediclin Research, Kolkata. She was the past Central Iap Pg member. Her special area of interest is pediatric infectious disease. She's been member of various national and international advisory boards and committees on immunization practice guidelines. She has more than 150 publications, and she's also a reviewer for Indian pediatrics. This is a very short resume of Dr. Manjuri Mitra. I will now request Dr. Sara Yasmin to start her presentation.
Okay, ma'am.
Make it full screen, ma'am.
Yes, sir. Start.
Yeah, please.
Is it visible, sir, ma'am?
Yeah, no, fine. Fair enough.
Okay. So, good evening, everyone, my revered teachers. I'm Dr. Sara Yasmin, junior resident at Institute of Child Health. And today I'm going to present a case which deals with common manifestation of a rare disease. So let's start with the chief complaint. We were faced with a 9-year-old male child who presented with complaints of intermittent pain abdomen and abdominal distension for the past 2 years. There was no history of jaundice, fever, bleeding, or blood transfusion. The child had been to various local practitioners where he had been managed conservatively. There was no significant past history. There was no family history of consanguinity. Just a second, ma'am. Developmental history was all right. The child was school going with a good scholastic performance.
Sarah, can we interrupt?
Just go back. Just
Yeah.
go back.
Okay.
That's Sarah.
You need
Junior.
to elaborate on your history of present illness. Can you give us a little more information
Yes.
on your? Yeah, there are
Yes,
two
ma'am.
chief complaints. Can you elaborate?
Yeah. So the pain abdomen was gradual in onset. It was like the constant pain abdomen. There was no increase or decrease, or there was no diurnal variation. It wasn't associated with any local abdominal changes. There was not associated with fever. And coming to the distension, the abdominal distension was gradually increasing in nature, more so in the left side, with a dragging sensation felt by the patient in the later time. And what else? That's anything.
Dr. Sarah,
Yes,
whenever
sir.
you have history spanning over 2 years, you are expected to detail the progression of each complaint.
Okay.
How many days it was lasting? Some 22 months back. How many hours or days it's lasting now? And what is the interval, whether it is getting shortened or the months? That will be for pain abdomen or abdominal distension. And you have to tell what is the sort type of pain, any relieving or factors increasing, like that. Okay. And whenever it is pertaining to abdomen, you have to tell about history of vomitings and some comment about stools, like that, because both the complaints are related to abdomen. Okay, GI.
Okay.
And
You need
also,
to give us more clear picture about the progression of the pain, type of pain, anything relieves, whether it is associated with any other symptom when it occurs, like that.
Okay, sir. So there were no such relieving or aggravating factors. The pain used to occur. There was no diurnal variation with the pain. There was.
Now, what was the duration of pain? Is it for minutes, hours, or days? Because it's spanning over 2 years.
Yes, sir.
What
It
is
used to
happening?
occur.
Is it static or it's worsening, like that?
progressive.
No, there wasn't worsening. It was a constant type of pain.
And distension, has the distension been progressively
Distension,
increasing?
yes, ma'am. Distension has been progressively increasing over 2 years, and more so in the left side of the abdomen.
And what about the general condition of the patient? Was the child eating
The
well?
patient was otherwise very active.
Growing well?
Yes, ma'am.
Was there any weight loss, fever?
No, ma'am. There was no complaint of weight loss. There was no complaint of fever. The child was otherwise active.
No history of blood in stools? Stools were normal?
Stools were normal. No history of vomiting.
What can be the causes for abdomen distension going on for 2 years?
Ma'am, there could be fluid in the abdomen. There could be.
You mean to say, no. What would be the first thing you would think? Fluid can go on for 2 years? It's a long history, no?
Yes, ma'am. So there could be organomegaly.
Okay.
The child could be obese, accumulation of fat, centripetal obesity.
Okay.
Then flatus, feces. This could be the causes.
Was there any history of constipation?
No, ma'am. The stool bowel habits were regular.
It's very normal. Okay.
Professor Manjari would like to add something at this juncture because she is not getting what we are talking about. Professor Manjari, ma'am.
Yeah. So basically, this child came with a 2 years history. When we got the child, it was referred to us, and in this 2 years, there was a gradual increase in the abdominal distension. The child was otherwise active, and they did complain. They did not complain of any bleeding manifestations anywhere. So there was no fever, and so I would say that I felt that the child was having some organomegaly, which was not having much of systemic involvement. Otherwise, there would have been some systemic involvement, and otherwise the child was also not fatigued, no tiredness, activity was good, just a slow increasing abdominal distension. A slow progress of any organomegaly was the first. Even without looking at the child, you can make out there was so slow increase in organ. And since it was on the left side, you could make out that probably a spleen was growing. So that is what was the initial thought. And there was no pallor, there was no facies difficulty that she'll come into. But overall, the impression was it was a slow progression of any organ.
Professor Bala, sir.
See, two things. Pain abdomen and abdominal distension going on for 2 years. Two independent symptoms or interrelated symptoms. And, once you have a pain for 2 years, you have to give a complete description of the pain so that we identify what is the anatomical area or what is the anatomical disturbance which is leading to the pain. To give examples of the etiopathogenesis of abdominal pain, a child can have abdominal pain because of a lesion in the abdominal wall, lesion inside the abdomen. It may be in the mesentery, and if it is a male child, it may be coming from a site close to the testicular region, from the inguinal region, from the inguinal lymph nodes, iliac lymph nodes, or it may be emanating from the intestinal wall, or it may be arising from the spine or from any of the viscera other than intestines and stomach, which include gallbladder, liver, pancreas. And I wouldn't forget retroperitoneal structures such as nerves, possible tumors, lymph nodes. Now, we have to identify which structure is probably causing pain. When you say intermittent pain abdomen, you should have described the location, whether it is colicky, right, left, center, lower, upper, radiation, aggravating, relieving factors, everything, without which I won't comment. I don't know what is causing the abdominal pain from the brief history she has given. That is number one. Number two, abdominal distension. She rightly said fat, fluid, fetus, and anything. We always flatus. That's what we remember as abdominal distension. This abdominal distension, she said it is coming from the left. Am I right, Dr. Sarah? Left. Upper or lower? From below upwards or above downwards?
That's what it was.
It was a vague pain. I would rather
Vague.
say it was a
No,
vague
distension.
pain.
It's not
There
pain.
was-
Distension.
Or distension. Yeah.
Which part of the abdomen is distended? You can make an anatomical diagnosis using the location of the abdominal distension. For example, I'll tell you, if it is a distension coming from the right hypochondrium, you only think of something related to liver. Whereas if it's a distension coming from the left hypochondrium, you always think of a spleen. If it is
So that
the
is what was, yes.
yeah, that I think anatomically you should have given a clue to us where the
I
distension.
think she told it was mostly on the left side. That is the reason
Which
which
portion?
and the
Which portion? Left means which? Right, left,
left upper has to be.
left upper. That
Yeah.
indicates that it could be a high probability of splenomegaly. Am I right?
Yes, yes. And the pain was intermittent and it was a
An
vague pain.
intelligent mother would even give you the direction of the enlargement. She would even say, sir, initially I noticed in the left upper abdomen, now it has come down to the right side also, indicating the way the
No,
spleen travels towards
No,
the reticulate fossa.
Yeah, it was
That's the
not
reason.
that, yeah.
Yeah, no.
But I'll tell you the overall, I'll tell you the impression was a vague pain. And as the result, the diagnosis, if it was any organic cause, the intestinal or any other thing, the pain would have been acute in nature. At least intermittently, sometimes they would have come, but there was no intermittent acuteness over 2 years.
Yeah.
So that was one of the findings which did not really clinch the diagnosis, whatever which went on for 2 years.
Yeah, in a child who's 9 years old, who has got pain for 2 years,
Yes.
something happening in the left hypochondrium, the probable organomegaly, I would have gone in depth into several other symptoms, which include appetite, school absenteeism.
Both of them were okay. Both of them were okay. There was no absenteeism. Appetite was also okay. Yes.
Easy fatigability, vomiting, constipation, about urination, everything, to find out which organs are likely to be involved in the pathology causing all this. With this history, I assume whatever she is talking about is an organomegaly, probably a splenomegaly, gradually increasing over the last 2 years. And of course, I don't know, she has not mentioned anything about dyspnea, anemia, pallor, she mentioned about jaundice. And
So I have mentioned those in the general examination.
no, just see, madam.
No, talking of the history. Talking of the history, Sarah.
But we don't need general examination at all. We can make a diagnosis with the history if you collect all this information. That is what we are trying to tell you. Don't worry. Why do you need to examine? History will give all the diagnosis. You can make out splenomegaly from the history. You can make out the etiology of splenomegaly also from the history. Right? Appetite, everything should have been included, including the presence of a male child having a testicular swelling, edema, oliguria, all those things should have been added. That's my comment. Okay. Please don't mistake, Dr. Sarah, that you know more about this case than what I know. But you have not provided information for any of us to zoom onto the probable historical diagnosis. I'm sure Dr. Ramakrishna and Sarah would agree. Right. Definitely more information. And more importantly, what has happened to the weight of the child in the last 2 years?
There was no history of weight loss.
Well, weight gain is there.
The gain was mostly because of the splenomegaly, I believe. There's a marginal weight gain, but no
you
loss.
Won't gain weight if it's a chronic disease. If it's a chronic disease, you won't gain weight. So again, those things are important. Everything is important in the history to give us a holistic diagnosis. That's what I'm trying to tell you, Dr. Sarah.
Yes.
Okay, sir.
Please go ahead. Please go ahead.
Dr. Sarah, you mean to say that the abdominal pain is not troubling the child by and large? Am I right?
Yes, sir. Yes, sir. The child was otherwise active. It was very
doesn't have much impact.
Didn't hamper daily activities of the child.
Okay, that's fine. Okay, we'll carry on. Before talking about developmental history, it would have been nice if you had mentioned about antenatal, natal, neonatal history and then developmental history. Continuation will be good. Okay. No, this is mainly for the purpose of presentation in the university exams. Okay. So what you are telling is being followed by many universities.
Dr. Ramakrishna, one correction. This is not only for university exam, it is also for diagnosis.
No, that is there at least for her.
I don't
no, sir. They're more focused on the exams. That's
but
right.
It is for our exams.
You are right.
It is for her exams in life, later in practice.
Yes, sir.
Let us not worry about the exam of MD or DNP. She is going to, like you and me. In fact, I always tell parents who come to me that sometimes don't reveal the information. I tell them, Ma, I was given a pass 40 years back. Don't keep an exam for me. You tell all the information which I want. So, every difficult case is an exam throughout our lives.
Yes, sir. You may move on.
Also,
That's all.
some additional history, like where does she come from?
From the peripheries
Patient
of
belongs
West
to
Bengal.
which place?
Murshidabad.
Why we want to know when in a case of an organomegaly which is going on for 2 years?
Ma'am, for to rule out
You
some
would like to
endemic
know that whether
diseases.
she's, yeah. So what endemic? Which place she's coming from? West Bengal. Where is she from?
West Bengal.
What she wants to say, is it plains or hilly area, tribal area,
Huh?
probably, right?
Okay, so
So
it's a plain.
you should also include that in your history. That also should be included in your history. See, we do not know the diagnosis, isn't it? As Bala sir rightly said that right from the history, you make 80% of the diagnosis is made from the history. So physical examination is just to confirm your suspicion, clinical suspicion. You will confirm by your examination. So we know this is organomegaly, probably spleen, going on for 2 years. So what endemic conditions do you think of? Endemic diseases?
Visceral leishmaniasis.
Okay. Is it there? Do you see such case there in West Bengal?
Close
No,
to
it's
Bihar.
not
That's what
very.
she's saying.
Yes, it's more prevalent in Bihar, but it's
Okay.
there in West Bengal too.
I will just ask, which states in India has leishmaniasis, Kala Azar?
Bihar, Jharkhand, West Bengal also has.
Yeah,
we
so
do
that's what I'm
have.
telling you.
We do have.
So you also have no. So that's
Yes.
exactly I'm asking you. What other endemic? UP, Jharkhand, Bihar, West Bengal, all are endemic for Kala Azar. What other endemic disease will you think of? Can you think of any other endemic disease?
Anywhere in the
Malaria,
country.
chronic
Yes.
malaria.
Chronic
Yes.
malaria. Yes.
What does that cause? What does that cause?
It can cause anemia. It can cause splenomegaly.
No. Or massive splenomegaly. What do you call that condition? Have you heard of tropical splenomegaly?
Okay, ma'am. Tropicals. Yeah, yes, ma'am.
So
Yes,
that's
ma'am.
very important where the child comes from, isn't it? Especially you saying that he's not associated with any systemic symptoms. The pain is not affecting the child. Probably somebody has accidentally picked up this finding.
Okay.
Except for the mild dull aching pain, abdomen, intermittent.
Regarding development
Okay.
issue, you would have told the development is appropriate for the age in all the 4 domains. We will be more specific. Okay.
Okay.
Right. Move on.
The appetite of the child is of paramount importance.
Yes, that's it.
Because Dr. Sara raised the possibility of, leishmaniasis or Kala Azar in West Bengal. One of the peculiar presentations of Kala Azar is that these children, in spite of a big spleen, anemia, their appetite is supposed to be well preserved. Of course, I have not seen many cases, but I've seen few cases. They don't have anorexia. In spite of a hemoglobin of 5 or 6 and a huge spleen right up to the right iliac fossa, these young children and adolescents may continue to have good appetite. That's a very important history data which you must elicit if you're going to think of somebody who has abdominal distension like this for a long time without anything else happening.
Move on. Right.
So in general examination, the patient was alert, conscious, cooperative, active. Faces were normal. There was no pallor, cyanosis, icterus, or edema. Lymph nodes, all the lymph nodes were examined, and there were no significant lymphadenopathy in any domain noted. The vitals were stable.
Dr. Sara, you are too brief, right? Where is the anthropometry? Anthropometry is missing. Growth charts are missing, especially it is over 2 years, right? Then comes vital data. You cannot say vital stable like intensivist, right? Even they also shall not talk like that. Even they also. Now try to elaborate. You have some information regarding anthropometry?
So growth, height of for age was at 50th percentile for the child, and weight per age was also 50th, 50th above 50th percentile, 50th to 90th percentile.
Right.
What is the BMI? Children above 6 years, you should calculate BMI, isn't it?
Okay.
What's your
Was it-
inference out of this?
Was it thin? The child was thin.
Sorry, ma'am.
Child was thin looking, appropriate, obese.
Appropriate, not thin looking.
What's your take after knowing the anthropometric parameters?
There
Probably
was
the disease is not affecting the growth. Of
Growth.
the
growth.
probably, right?
Hmm.
Okay. You should draw inference from each and every symptom, sign, and observations, and correlate and analyze. Okay. Regarding vitals, throw us some more light on vitals. Always mention different heads, 5 heads at least. Pulse.
Pulse rate was approximately about 74 per minute. Volume regular. Volume was normal. Pulse was regular. Condition of the arterial walls was normal. There was no radial or radiofemoral delay. About BP was between 50th and 90th percentile. Respiration was regular, symmetrical, and rate was approximately 28 per minute. Saturation was maintained. Temperature, the child was normothermic, and temperature.
Saturations are normal. Right. Okay. Carry on.
Also, you should look for other peripheral signs of any liver disease. Important.
It's not very clear to me. Whereas Sarah's and the other voices are clear.
Hello.
Hello. Yes.
Yeah. Can you hear?
Yes, ma'am.
Can you hear, Sarah?
Madam, your voice is clear, but Ramakrishna's voice is very distant and broken.
Okay. Okay, sir. I'll try
No,
to
I am
correct it.
asking her when she's thinking of probably a big spleen. In the general examination, you should also mention the signs of any peripheral signs of liver disease.
Ma'am, there was no Palmer erythema.
Mhm.
There was no jaundice. There were no distended veins.
Yes.
There was no ascites, free fluid in the. There was no free fluid in the abdomen.
That you will come in the GIT.
Yes, ma'am.
What else on the skin?
The skin was normal, not paper thin skin.
Okay.
But
Is it important?
yes, ma'am. It tells us about the involvement of the liver disease and how extent of liver disease, if it's involved.
So whether this can be a chronic liver disease?
Yes.
So that
No,
also you should try to rule out from your examination, no?
Okay.
Are there any features of liver disease?
No, ma'am. There were no features of liver disease.
Spider nevi you looked for?
There were no spider nevi. We look for the spider nevi generally on the face and upper chest, but there were no spider nevi.
Any skin pigmentation?
Sir, can you please repeat your question?
Skin pigmentation.
No.
Bala sir, your comments.
Yeah.
Examination. Yeah.
General examination, clubbing is very, very important. Liver disease. As you
That she
rightly-
forgot. She
as you-
forgot clubbing. Not mentioned.
Sorry.
And more important, what is the general appearance of the child? Is it a well-looking child or a ill-looking child? That is very, very important. And in fact, for somebody who has got such a big, such a chronic abdominal pain and distension, I would even mentioned about the sensorium of the child in the general examination. And she has put in the systemic examination no significant finding on inspection.
Yet to come, sir.
How can there be no significant finding? So you are, you are talking about a spleen which is 12 centimeters. How can the inspection be normal? You have pictures of the child?
No, sir, don't have.
No, the wording should be nicely coined, right?
I can't imagine somebody who has got a spleen palpable 12 centimeters below left costal margin.
That will be visible.
Absolutely. There will be definitely, the spleen will be visible, not even palpable, it will be visible.
Are you getting the point, Sarah?
Yes, ma'am. Yes,
Yeah,
ma'am.
because 12 centimeter means it's always crossing the midline, almost come to the
I
right
would
to
have,
left fossa.
shall I tell you, even without seeing the patient, I can tell you the inspection findings will be the umbilicus would have been pushed down,
Opposite.
stretched to the right, transversely split, left hypochondrial fullness around the umbilicus. Okay, is massive splenomegaly, with the flanks, with the left flank being full and the right flank being relatively not full. That would have been inspection finding in this child.
But Sarah, you are too brief. Okay.
Yes.
Examination of the GAT shall start from the mouth. Examination of mouth, then you come down. Right? Examination of the respiratory system from nares. Examination of the cardiovascular system from nares to neck to chest. Like that. We will be systematic. Examination of the oral cavity.
Okay. So should I say from the oral cavity part? Should
Yes,
I say
yes.
the exam?
Yes.
Okay. So from inspection from the oral cavity, there was no aphthous ulcers. There were no gum bleeding. There was no gingival hypertrophy. There was no halitosis. There were no dental caries. Apart from that, in the general examination from inspection, there was fullness of the left iliac fossa, left lumbar lesion,
Iliac fossa.
left hypochondrium and left lumbar lesion, and extending the swelling also extended to umbilicus. Umbilicus was everted, pushed down towards right. There was no distended veins, no localized swellings, no skin changes. Yes. The hernial orifices were within, there were no hernial orifices noted.
Posterior abdominal wall, normal.
Okay.
Cranial angles are free. Okay.
Okay.
Don't forget about commenting on posterior abdomen.
Okay.
Right. Yes, move on.
Coming to the palpation part, superficial palpation, temperature was normal in all the quadrants, all the 9 quadrants of the abdomen. There was no localized tenderness. About the deep palpation, liver was just palpable. The liver margin was rounded. Consistency was firm. There was no fixity. About spleen was 12 centimeter below left costal margin. Splenic notch was felt. The consistency of the spleen was firm. Margin was rounded. There was no overlying tenderness noted on the spleen. There were no skin changes associated.
Okay, you may say abdomen is soft. no local range of temperature, skin and subcutaneous tissue are normal, abdomen is soft, not tender. Then describe about liver and spleen. Tell that there is no other swelling palpable. Apart from viscera, there can be other swellings also, like lymph node swellings, right? Retroperitoneal swellings like that. Okay. And posteriorly, no renal angle tenderness. Dr. Subramanya, your comments.
I was thinking of what can be the disease. So if I were to think of common causes of splenomegaly, it can be infections, chronic liver diseases, some of the storage disorders, autoimmune disorders, malignancies, and so on and so forth. If I were to come to rarer forms of infections, in infections only commoner ones could be malaria, etc. Rarer forms can be Kala Azar. I don't know, Kala Azar is rare for us and maybe more common there, I don't know. But things like leishmaniasis and other rare infections. In autoimmune diseases, for example, you can think of even rheumatoid arthritis. In malignancies, commonly we can think of leukemias, lymphomas. But the point which, if I were to take today's theme and going on to the rarer variants, then you can think of some adult forms of leukemias in childhood as presentations, which can present with massive splenomegaly. Storage disorders can be Gaucher's, Niemann-Pick and other things, which will be associated with some other features. But currently, this child was otherwise well child, and taking those possibilities out. Now, can this be simply hypersplenism and hematological disorders like thalassemia? But the point is that there were no systemic manifestations. Dr. Balasubramaniam inquired further to know if there are any systemic manifestations present, but there was no other clue. Could it be something like hypersplenism and tropical splenomegaly and things like that? The point is that these are the diagnoses which will get unfolded as the investigations proceed further. Now, I'm yet to get a point on whether there is fluid in the abdomen or not, because that will get cleared by palpation. Till then, I'm keeping my fingers crossed. Suppose there is no fluid, then straight away it boils down to all causes of splenomegaly without fluid. And if it is with the fluid, then that will be the question. Now, the only point which I am not very comfortable right now is that you say that liver is just palpable. Now, whether it is hepatomegaly or whether it is just that the liver is palpable. Sarah, can you please tell us, because something about the liver?
It was just palpable, sir. It wasn't even full 1 centimeter below RCM.
And should I take it as normal or abnormal? And at times, some people can try and see, and if you palpate, liver can become, yeah. What is the liver span? Now, that will come in palpation, or you wanted to comment on this right now better? Because hepatosplenomegaly takes us elsewhere. Absence of hepatomegaly and only splenomegaly takes us somewhere else.
Okay.
Any information that you could give me regarding that? You have put us on the edge of just palpable liver. When there is a splenomegaly, the answer will not lie in just spleen. One is the answer will lie in whether it is mild or massive splenomegaly, or what is the status of the liver. So it's a total disease for which common etiologies that we need to think of, or isolated splenomegaly causes, because that's how we can approach this case even clinically also, taking the histories backwards. Now, I have got only one point to tell you, that the child might have become symptomatic from past 2 years, like pain abdomen. But if you take splenomegaly as dragging, that means that onset of the disease is not just 2 years, it is earlier to 2 years. And might be the spleen has enlarged over a period of time, but became large enough to become symptomatic in terms of dragging pain from past 2 years. So if I were to give my inputs, probably I will add 2 more years to it. The way in which the spleen has been progressing from what it was causing, dragging to further becoming symptomatic enough to reach up to the doctor because of the pain, not because of swelling, distension. So if I were to go by the pain analysis itself, the entire etiology may be drawn over 3 or 4 years, which will put me lower down as far as malignancies are concerned. I'll keep up on the parts of infections, which can remain subclinical, undiagnosed for long period of time. But the problem is that there is no history of fever. This puts me into those kinds of rarer diseases like immune mediated diseases and others. Others means there is a long list of rarer and rarer causes which will not right now. Maybe I'll not be able to give a list right now, but it puts at least for us common infections down just because of the presentation of a very prolonged period of time and continue becoming symptomatic of late from past 2 years and continue to be not very, very rapidly progressive, very, very slowly progressive. The disease is not progressive, but the splenomegaly is slowly progressive, slow enough that the patient is otherwise looking well, his growth and development is not affected. There are no constitutional symptoms. So it is rather a kind of disease which is very, very slow, and that's the kind of category that I want to put. I think all the other co-panelists would agree with me on the thought process. Now I need some more information from palpation and some more information from percussion and
Sir, the
topography.
liver span was 10 centimeter.
So you wanted to put it in up. You want to put it in the bracket that there was no hepatomegaly, correct?
Okay. Yes, sir. There was no.
Yes.
Okay. So we should think of isolated causes of splenomegaly from probably rarer forms of the disease, given that this vague symptoms has been stretching over 3-4 years, and off late from past 2 years it has become symptomatic by dragging pain. So taking this in consideration, this itself will put commoner diseases down the list. However, because the commoner diseases exist, we cannot just rule it out like that, considering theme of today's presentation. So now the balance between common diseases and uncommon diseases becomes widely open. Now I'll stop here.
Yeah, I am little surprised that this child does not have any pallor. Or is it that he received any transfusions outside?
No, ma'am. The child did not receive any blood transfusion. Even the hemoglobin, as I'll show you, was not very low. It was lower than the...
Labs later.
Clinically, there is no pallor.
No pallor.
Madam, these negative findings itself will take out most of the common diseases that are running in our mind.
Yes.
When we ask for pallor, we are thinking of pallor plus splenomegaly. When we are asking weight loss, we are looking at malignancy. When we are asking for negative history of lymph node, that is putting us further down in terms of lymphomas, leukemias, and others. When we are asking about development, it is putting us down in terms of some of the storage disorders or systemic manifestations. Absence of multisystem presentation itself is putting down in thinking of commoner multisystem diseases that are there. So the jury cannot be out from just clinical history alone, but we can tell probably what diseases we need not think of. However, we can't rule them out.
Even hemolytic we need not think of because faces were normal. Such a huge spleen, no pallor, face is normal. So hemolytic also gets ruled out.
Yes, ma'am.
Yeah, at least we can confidently tell that. Not only hemolytic, madam, most of the common diseases only we can take it out from our discussion.
Yes, even malignancy
because
for
there is
4
no
years,
supportive second symptom other than splenomegaly for most of the common diseases.
Yes, as of
this case has no other finding apart from massive splenomegaly.
Okay, Dr. Sarah, from your findings and the history, this child is 9-year-old, has had abdominal distension without any other systemic symptoms, and nothing else happening in the child. No bleeding from the GI tract, no progressive pallor, no jaundice, no fever, nothing else. And on general examination, well-preserved child without anemia, cyanosis, jaundice, etc., without any lymphadenopathy. The child has got a massive splenomegaly. It has crossed the midline. Am I right?
Yes.
Yes.
It's a massive splenomegaly. To me, forget everything. When there is splenomegaly, the first thing I do is to classify the degree of splenomegaly, whether it is mild, moderate, or severe, or massive. 3 centimeters, 8 centimeters, more than 8 centimeters. This is more than 8 centimeters. This is massive splenomegaly. So, one massive splenomegaly, well child, no anemia, no jaundice, no ascites, no significant hepatomegaly, right? No fever, no lymphadenopathy, nothing else is there. Once you have massive splenomegaly, I will go back to the anatomy of the spleen. What are the parts of the spleen, Dr. Sarah? No?
Red pulp and white pulp.
What is the red pulp? What is white pulp? No, that's how we should approach this case. You go from the fundamentals, you will get a diagnosis, I can tell you, without investigation. We will try.
Anatomy
Yeah.
and
What is white pulp?
physiology of
What is red pulp?
spleen.
White pulp has the reticular tissue, and red pulp has splenic sinusoids.
See, basically, white pulp is an immune affair.
Lymphocyte,
Pulp is a storage organ. That's how you should remember. See, to me, from my anatomy days, this is how I remember the functions of the spleen. White pulp takes care of the immune system. Red pulp is like a storage tank. Okay. Now, tell me, in this child, do you think there is some problem with the red pulp or with the white pulp?
The red pulp.
Why red pulp?
There is no anemia, nothing.
No anemia, nothing is there, no thrombocytopenia, no petechia. Why do you blame that? Why do you blame the red pulp?
But sir, like if the immune part is affected, then shouldn't the child have
It is
repeated
not only
infections?
the immune part, the white pulp also, in addition to the immune part, has also got other cells. What are those cells? What are those cells? Lipid storage cells. Storage cells. Okay. Storage cells. It may be lymphoid cell hypertrophy, or it may be more of some other storage cell in the spleen. So to me, in the absence of anemia, thrombocytopenia, infection, lymphadenopathy, hepatomegaly, jaundice, I guess that there is a problem with the white pulp, with some infiltration of cells, which is probably not malignant, which is probably not WBC or RBC, which must be some other tissue, some other cell. You get my point, Dr. Sarah? I'm going into the anatomy.
Yes.
Okay, that is one. The second part, to me, when there is splenomegaly, the next question I ask is there hepatomegaly or not? So when you have an isolated splenomegaly, which is massive, in fact, in my PG lecture classes, I always tell a DCH PG, exam going PG should tell at least 5 common causes. An MD PG should tell at least 10 common causes. Okay. Now I'm asking you, Dr. Sarah, or somebody, the other students who are watching can also put in the chat box. What are the causes of a massive splenomegaly? Let us analyze one by one and let us see where it fits into in this child. Massive splenomegaly. There can be only 4 causes. You have only around 10 to 12, I can tell you straight away. Tell me, what is the commonest cause of a big spleen in pediatric practice? You should tell me. 90% of big spleens will fall into thalassemia, I can tell you. That too in your part, Bihar and all those areas, Chhattisgarh. Second is portal hypertension. Is this thalassemia? I would straight away say no.
No.
The child has not had a single transfusion with such a big spleen. out, straight out.
Face is normal.
Second is this portal hypertension?
No, sir. There
Why
is no ascites. There are no varices.
No. Why not? All portal hypertension, should it have ascites? What are the types of portal hypertension? What are the types of portal hypertension? Again, I'll make it easier for you. Once you have a spleen, the spleen is a spleen enlargement. Either it is due to infection, infiltration, space occupying lesion, congestion, and others. In this child, infection is straight away ruled out. Nothing is happening in this child. It has to be only an infiltration. An infiltration causing big spleen, you have a lot of causes. The most common being chronic myeloid leukemia, leukemic infiltration, Hodgkin's lymphoma or non-Hodgkin's lymphoma, your HLH. In fact, once we talked about Kala-Azar. Leishmaniasis is one of the very important treatable causes of HLH. It's very, very well reported in literature. Of course, fever is not there. Okay. Right? And congestive splenomegaly may be because of portal hypertension. And this portal hypertension is very, very unlikely in this child. But 9-year-old, such a big spleen, no anemia, no thrombocytopenia, no GI bleed, extrahepatic or pre-sinusoidal portal hypertension is extremely unlikely. Then you have spherocytosis, hereditary spherocytosis, very important cause, common cause. No anemia, no gallstones in the family, straight away not there. Then you have storage disorders. In fact, my guess in this child is that it could be a chronic lipid storage disorder. Because there is no hepatomegaly. If there is hepatomegaly, I would have thought of a carbohydrate or an amino acid disturbance. There is no hepatomegaly. It could be lipid storage disorder like Gaucher's or Niemann-Pick. Okay. Then other causes of massive splenomegaly include hairy cells. Subramania mentioned about rare adult types of leukemia causing massive splenomegaly. Remember, acute leukemia doesn't cause massive splenomegaly. Chronic myeloid leukemia can cause massive splenomegaly. Massive splenomegaly can occur in hairy cell leukemia. Right? Then other rare conditions include HLH, which can cause a massive splenomegaly, hemosiderosis or hemochromatosis. Right?
Sir, myelofibrosis.
I'm coming to that. Myelofibrosis. Myelofibrosis will cause anemia, child will be sick. Again,
Yes, I know. It's more common in adults.
Myelofibrosis, osteopetrosis, pycnodysostiosis can all cause massive splenomegaly. Right? Rarely splenic tumors, hamartomas in the spleen can cause a big spleen like this. Right? So these are all the conditions. But having rarely even tuberculosis can cause some massive splenomegaly. Your Kala-Azar, brucellosis can cause a massive splenomegaly, however uncommon it is. LCH, Langerhans histiocytosis can cause a massive splenomegaly. In fact, I have gone beyond 10. I have given you almost 16 conditions. Now, of these 16, because of the absence of jaundice, anemia, fever, massive hepatomegaly, significant hepatomegaly, lymphadenopathy, well child, only massive splenomegaly, no bleeding, I am thinking of an infiltrative disorder and probably some rare storage disorder. That's my conclusion with this history and with this finding. Thank you.
Dr. Sarah, move on.
So the percussion and
See,
auscultation.
don't
cells
say
are
no significant findings. You say on percussion, abdomen is tympanic. You tell positively. Right? Don't
Yes,
say
sir,
nothing
actually.
like significant. Okay.
And I forgot, just 1 minute, I forgot to mention 2 other conditions. One is autoimmune hemolytic anemia. That can also cause a massive splenomegaly. Very rarely, systemic lupus erythematosus, and Felty's disease, your systemic onset rheumatoid arthritis can cause a disc pain. That's extremely rare, right? Thank you.
Yes. So on percussion, the abdomen was tympanic. Shifting dullness was negative. And on auscultation, there was no abdominal bruit.
Continue.
Anything?
Yes.
Okay. Serious examination, the S1 and S2 were present. There were no added sounds, no murmurs. Other system examinations were, sir, within normal limit. So I didn't mention here. Do I go on for the respiratory system and others? Should I tell?
Normal, is it?
Yes, sir. There were no findings.
Right. Yes.
So
There is nothing much to sum up because you have only one finding, which is very
Only.
significant.
Yes.
You tell your clinical diagnosis.
Clinical diagnosis, sir.
What differentials you thought of?
Okay. So
1, 2,
for
3.
my differentials were hematological hemolytic anemias, then amongst
Will you put,
infiltrate.
Is that the first differential in this child?
Yeah, put it in the order. Put it in the right order.
You must put it in the, I always believe that clinicians put an odds ratio in the diagnosis or in the differential diagnosis. You must know which are the conditions which are more likely before you talk about conditions which are less likely.
So my first, the diagnosis we thought of first were infectious. Amongst infectious were visceral leishmaniasis, CMV, and EBV infections. But since there was no history of fever, we have ruled out infectious.
CMV, EBV generally causes massive splenomegaly.
EBV causes soft, not massive, but they do cause splenomegaly. Kala-azar causes massive splenomegaly.
Yes.
CBV, EMV doesn't cause massive splenomegaly.
Yeah, at least if you have thought of chronic malaria, that would have been better in infections.
Yeah, congestive splenomegaly, Kala-azar, brucellosis are all very, very uncommon causes of massive splenomegaly. Of course, you have to think of them in this case, but not in this child because there is absolutely no fever. Nothing else is happening in any of the systems, no systemic symptoms at all in this child. So I don't think I will entertain infections as a possibility at all in this child. But even HIV can cause sometimes massive splenomegaly.
Yes, HIV can.
So the second our differentials was hemolytic anemias like thalassemia or autoimmune hemolytic anemia. But since the hemoglobin was through and through, there was no pallor, there was no history of blood transfusion, there were no abnormal faces. So we could
when
rule
there are
that.
no pallor, no icterus, no history of blood transfusions, why should you consider it in the top of the table? You prioritize the probable diagnosis.
So probable diagnosis was infiltrative. Could have been malignancy or storage disorder, most likely.
Professor Manjari ma'am, would you like to come in?
Looking at, as Dr. Balasubramanian so nicely has come, I was just hearing him. Now, this case has come to us at the last, after roaming across India. So all those we thought and all she's discussing was diagnosed first, but in spite of all this, that the patient did not have pallor, no signs of extramedullary hematopoiesis, still thalassemia was ruled out, HPLC was done. In spite of having no, there was no signs of extra portal hypertension, extrahepatic portal hypertension, still endoscopy was done. There was no sign of any malignancy, 4 years hepatosplenomegaly gradually growing. There was no sign of malignancy, but still bone marrow was done. So, and that went from Kolkata to Hyderabad to very premium institutes, and it was just going on. So if I have to say something, I would rather like to say the way Dr. Balasubramanian, I hope all the postgraduates listen this carefully, how one has to go through a case, evaluate very meticulously, just not do a battery of investigations, looking at a splenomegaly. So if you really coin down through the history, and if you think of all our processes, we save battery of investigation and we can pinpoint, as Dr. Balasubramaniam said, we should think of a storage disorders. So that is
I would
all it
first look at
comes.
the fundus of this child. I would first look at the fundus of the child and look for a cherry red spot in this child straight away, or ask the ophthalmologist to immediately look for a cherry red spot. And that's going to give me a diagnosis straight away.
Yes.
Professor Srinivasan, your inputs. Professor Srinivasan. Okay, no, move on. Dr. Sarah, anything else you would like to tell?
No, sir. Yes.
Sir, I would put Niemann-Pick on top.
Agreed. Because the whole thing is not a lipid storage disorder is most likely lipid storage disorder. And there is this dysmorphism to suggest any mucopolysaccharidosis and other conditions. So it looks more likely a lipid storage disorder. Maybe Gaucher's and Niemann-Pick's.
But Gaucher's, I would have had hepatomegaly. So, sir, I will, narrow it down to Niemann-Pick on top of the other variants.
Some types of Gaucher's may not.
Gaucher's,
I agree on this point, sir. No, the
Gaucher's
theme
may
is
not have
rarer disease, we never know. But storage is going on top than any other infections and malignancies.
And I would like to say here, sir, sometimes it may not be easy to differentiate clinically between Gaucher and Niemann-Pick's.
Yes.
Clinically.
Agree.
Second question, I think all the faculties can also comment. I want Sarah, our student Sarah to also reply. What about persistent antigenic stimulation and splenomegaly? Like it happens in, let's say, malarial antigen or some of the infections, there is continued antigenemia and splenomegaly. So this is a situation where, the cause is not infection, but infection related. So, was there any angle or any investigation being done in that direction?
Sir, all the routine tests, including malaria, was done, which was negative. And the child also didn't have history of malaria, fever, anything.
Now, one small question I missed for a while. ESR?
No, investigation she has not shown, no?
Not yet.
She has not come to that.
Right. Show some investigations.
Can you show the investigations?
This case requires, right?
Because otherwise we'll be guessing with 12, 13 possibilities.
These are the charts, but like malaria was done, it was negative.
So there is thrombocytopenia.
Yes, persistent.
Yes.
Madam, this can be because of hypersplenism, nothing else.
Yes. No bleeding manifestation.
There is actually bicytopenia. Hemoglobin is 8.
Anemia is also there.
Bicytopenia. In fact, I would say even pancytopenia, because in one of the counts it is 4,400. So this is pancytopenia, and most probably the pancytopenia is because of the big spleen. You expect the child to have a pancytopenia, right? And I don't know how reliable this retic count is. Extremely unlikely. Retic count, I would expect it to be high in this child if it is hypersplenism. Right? Fine.
And anything
Can you
else?
tell us, Sarah, the criteria for hypersplenism?
Ma'am, spleen of any size.
What is the difference between hypersplenism and splenomegaly?
Ma'am, in hypersplenism, spleen can be of any size.
Yes.
And
one is of the function.
One is anatomical, other is functional. Right?
Functional. Okay. So what are the criteria?
Ma'am, spleen of any size with pancytopenia, with normal or hypercellular bone marrow.
Yes, that's very important. The marrow should be hyperfunctioning. It is because of peripheral destruction. That's why we expect the retic count to be high, which is not so here.
Move on.
Oh, so these are the differentials we had thought of, as I was saying.
Any peripheral smear? You should have gone for peripheral smear also. Did you have?
Sir, these are the peripheral smear. Yes, sir, but peripheral smear, nothing significant was there. It was normal.
You should have mentioned it. Okay.
So one significant was USG was done. USG showed gross splenomegaly with mild hepatomegaly, normal flow in splenoportal axis. Doppler studies were nothing significant other than which revealed dilated splenic artery with increased flow but normal flow pattern. These are the battery of tests which were done before the child came to our institute.
What is RKF 39?
Ma'am, this is for the visceral leishmaniasis which is done. Should I continue?
Yes, yes.
Bone
Yes, go
marrow is
ahead.
done. Bone marrow?
Yes, ma'am. Bone marrow was done.
It was normal.
Bone marrow was done. This showed histiocytes with normal erythropoiesis. Trypan biopsy confirmed Gaucher disease with presence of Gaucher cells in bone marrow.
What about the ophthalmologic examination?
So that wasn't
was-
mentioned anywhere. It wasn't done probably.
Like you knew the diagnosis also.
Yes, sir, but like it wasn't in the papers.
Okay.
So this one was actually done in Hyderabad, and the child was sent to Kolkata to Center of Excellence for further treatment.
Now, Dr. Sara,
Yes.
this is why I stressed earlier in the history. From the history,
Yes, sir.
straightforward. This was not infection. This was not malignancy. This
Yes.
is not anemia.
Yes.
In fact, you don't even have to examine this child. From the history, you could have made a diagnosis.
Yes.
Storage disorder.
Sir,
Causing
Sir,
a
if you could
Yes.
recollect, I told in
I
the
would
beginning that
say
there
that-
are maybe more than 2 years of history, and last 2 years are only symptoms of massive splenomegaly. And the
Absolutely,
very
yes.
fact of duration of the disease, it will defeat most of the common causes.
Right.
Yes. But unfortunately, even in today's era, it had to nearly travel for 2 years to get a diagnosis. This is the unfortunate state, and I would like to highlight, if I may be allowed, are we discussing
Yeah.
anything with Dr. Sara?
Yes, madam.
Madam,
Please go ahead.
madam, sorry, before you go, let me tell you one thing. What
Yes.
happens is that when we get a patient referred from 3 or 4 places, it may be that we don't think of those diseases. Suppose if we were to first of those 3, 4, then we will end up doing the workup of them, and then, let us see on follow-up, or let us see the evolution of the disease. And many times it gets shifted. And when we receive after longer duration of time and multiple visits, paradoxically, it could be at times that, it becomes easier,
Easier.
but it is not necessarily always.
No,
So
that is where I want
Can
to.
I add one?
Yeah, it
Yeah,
works
please,
both
please.
ways.
I want to
It
add one
works both ways.
thing.
Please
Sir,
go ahead,
This
ma'am.
happens also. This happens also if the patient goes only to a specialist. If this patient has first gone to a gastroenterologist, he will definitely think of a portal hypertension, even if
Yes,
there
that
was
has
no
happened.
symptom, and probably would subject the child to a endoscopy.
Yes.
If he goes to a
Yes, that has
hematologist,
happened.
he would like to rule out something like a thal intermedia, where you can get big spleen. He might not have had this thing, bile pallor, so he would investigate in that line. That could have happened with this child, I suppose.
Yeah, if they go to ID specialist, they will rule out every virus and a bacteria.
Subramanya,
No,
I
but-
wouldn't have done anything.
No, sir, not for you.
No,
but
no,
for
no.
others.
I wouldn't do any viral studies for this child, except maybe.
No, I was generalizing, sir. Not every
No.
virus and every bacteria means going on taking out everything, digging out all possibilities of infections. So it does happen, and all of us have got some role to play at some part of the time. We will be the mimickers of each other. That's fine.
Yeah, so last slide, Sarah. Then I'll say something more.
So the patient, when the patient came to us with intractable convulsions, was admitted in ICH. MRI EEG brain was done, which was within normal limit. We sent for enzyme assay and genetic analysis. It showed reduced glucocerebrosidase activity in the blood, and he was diagnosed with type 3 neuronopathic Gaucher. And from here, the patient was advised hematopoietic stem cell transplant and enzyme replacement therapy. But
So here,
then, yes, ma'am.
yeah, please tell. So here I would like to say what is happening in today's because the rare disease is and awareness is being spread amongst rare disease. There was a mistake in my understanding when Dr. Sarah told me that I have to make a presentation. I thought it was something different. I never attended DIP. So very last moment, yesterday only I had to tell Dr. Sarah or Yasmin that we have to make a PG presentation. So there was a lot of lacune in the whole process because she was neither aware and it was a very last moment thing. So my message to the whole process, why I wanted to bring out this day. Today, we are having a lot of rare disease panel. The government is also giving support for rare disease treatment. And today we are spreading awareness in rare disease. The basic statement says that what is rare today, Gaucher may be 1 in 40,000, but total all put together rare disease is 1 in 7,000. That is what is coming in the entire storage, and lysosomal storage disease has a lot of diseases. There are treatments. Government is giving us support. That nodal centers, the center of excellence, giving us support 1 year, 2 year. Now it will be slowly in that process. So our message to the postgraduates, because during our postgraduate, maybe rare disease was not so focused, but now our message to the postgraduate, if you have a splenomegaly and a low hemoglobin, and if you don't find any cause, please do a simple DBS, that is a dried blood spot. In a filter paper, you have to take only small blood drop, and you can do the enzyme assay. And with the same, if the enzyme is positive, the same thing will be sent for mutation analysis. All these are coming free of cost. It is available everywhere in India. So that is what was the importance, why I wanted to present this case, that the awareness has to be built into each of our system. And a patient in today's context should not go around like that. Unless and until we have an awareness, it will go around. That was the message. That was the message I wanted to say. And even it has been seen, because enzyme replacement therapy means 50 lakhs per year till lifelong. Now, there are 100 subjects who are being treated in a compassionate access. And even there are Gaucher patient who has been subsequently carried forward in adulthood, married, and got 2 siblings without any Gaucher. There are subjects in Gaucher after treatment, they are leading a normal life, studying medicine, studying engineering, entering into a normal life and lifelong. It is something like taking Eltroxin. Since the Eltroxin comes in paisa and this comes in lakh, that is the difference. So that was the whole message. And if you diagnose early, then recent thing which we have just discussed, we had a meeting in Delhi. So it was seen that even if you do HSCT at an early stage, that can be a curative. You give few days, months of ERT, do an HSCT, and again few months of ERT. You don't need a lifelong. So that becomes a curative. Now people are moving towards that. So that was the message of the entire study. And as I would again say, as Dr. Balasubramanian analyzed, I hope all the PGs understand how we have to go from the history itself. You can make a diagnosis from the history itself. It was a very classical history. I understand that it becomes easier, but if you have a orientation, if you have a mindedness for a rare disease, particularly the lysosomal storage disease, which is now coming in a way, the awareness has to be built so that you can diagnose, the patient gets treated. The patients are also there's a lot of support group coming up. So they have their lysosomal storage disease support group as there. So they now moving across the government area and all those things, and they are getting the treatment. And the patient, if gets the treatment earlier, the diagnosis, the prognosis is pretty good, pretty good. That's all was my summary. Yeah.
Manjari madam, I have got a question. Maybe
Yes,
the
please.
question can be answered by other faculties as well. And I even personally had a dilemma on this. Let's say in 2 investigations, they have done peripheral smear for malaria. Let's say in 2 places, they have done a reticulocyte count. They have done a total count. And they have done some investigations. When it comes to us, should we start from A to Z, or we should start from M and N, then move on to the Z? I think I'm just putting the question very simply. Is it that if the investigation has been repeated in 3 or 4 places, should we have to again do one more CBC at our institution, one more peripheral smear? My point is that, I will come to the point. Most of the patients, when we see practically affordability, then second question is duration of stay in the hospital. Suppose somebody has done the bone marrow and it is negative, let us say. Should you have to repeat the bone marrow?
Hmm.
So how will you take that call? And I want each faculty to comment because PG say हम बाहर का report नहीं चाहिए, हमारा report चाहिए. Is it that the बाहर का report is wrong? And when it goes to the next institution, ours also become बाहर का report.
No, it depends on your clinical because that is what was the stressing point of today. You have to do a very good clinical diagnosis. If you make a clinical history, if you take a very good history, 2 years history with the recent onset of dragging pain, huge splenomegaly, no signs of any anemia, no signs of bleeding, no signs of fever. So my first 3 points is ruled out. Hemolytic is ruled out. So I don't
Madam,
need to
my
repeat.
question to you is that, for example, I'm just coming back to some introspection. Maybe in,
Yes,
me in your
yes,
place
yes.
would have repeated transferrin, serum iron, and repeating a panel on.
My peripheral
Yeah,
smear
so-
is showing is not showing microcytic anemia. So then why should I repeat when I'm not seeing that anemia, that iron deficiency or transferrin will not give rise to so big a spleen. My target is to find out the cause of the hypersplenism or cause of the splenomegaly. So iron deficiency will not give rise to such a big spleen.
Fair enough.
Then
I got a point. I wanted to just ask our jury, Balasubramaniam sir, how often when you
I think, sir,
get a referral from other pediatricians having worked up, how often you repeat the investigations, and in which situations you'll repeat, in which situations you will say, okay. I'm sorry for a vague question, but sir, from your experience,
no,
few tips.
it's an important question, I believe.
I see the problem in India is that unlike the West, say in US or UK, you get a lab report from anywhere in the country.
it's not the same.
Trust a lab report because most of the labs are automated, standardized, and they are regulated. But in India, I'm afraid the situation is extremely, I would say, extremely unreliable. I can't believe even a hemoglobin report from many a lab. So if you ask me, if it has not been done in a known good lab, definitely I wouldn't believe the labs, particularly when I have a difficult case in front of me. I would definitely repeat essential investigations. I'm underlying essential. I might not be repeating tests like transferrin iron, etc., but a complete blood peripheral smear are the basic tests which I will do in our lab, where it is automated and it's confirmed by a pathologist. I would rely on that report. That's my answer for you. But I don't.
Sir, fine, sir. I got the answer, but I want to put the question to Sarah Madam and Ramkrishna who are in the institutions. Madam, will you do the investigations because the
Yeah,
PGs need to learn, or will
no,
you do the
I-
investigation because you want to diagnose? I'm sorry for
No.
asking this straightforward question.
I would agree with Bala sir that we cannot trust the labs. Many labs, the DMLT person sees the PS. So one is the reliability. Secondly, I would look at if the patient's financial condition, and also if I'm thinking of a different diagnosis, definitely I would reinvestigate. If I'm thinking in the
Okay.
same lines and if the lab is reliable, just for the PG, I may not tax the patient if that is the case. If the lab
You
is
won't
reliable.
you won't repeat the test to rule out something
No,
which is in the opposite direction of your thoughts. Obviously.
Yeah, no, if it is in the opposite direction of my thought, I would definitely repeat.
So, for example,
If
RA
I'm thinking of a
factor,
different diet.
RA factor in this particular patient, will you repeat or will you not repeat outside?
RA factor,
No.
why do? It's a waste of money. Subramania,
So
RA factor is not to
I'm
be
coming
done
to that
for
question.
for
Correct,
anybody.
sir.
I'm
Correct,
not-
sir. No, I'm putting that question. No, I'm putting that question. Only that such investigations we should never repeat.
No,
Sir, in
RA
this question, I would have.
Subramania, I have
would-
not done RA factor and Vidal for the last 10 years. Where
Yeah,
is
we
the
also
That's
don't do.
exactly what I'm coming to, sir. Those
Yes.
investigations
Subramaniam, sir,
which
at the most,
which may not be relevant, we will not even think of anything, but
would
just
have-
to
yeah.
suppress them.
I would have asked for a good PS, peripheral smear, because that is something which, which can be missed if it is not done in a proper lab.
Let us say this patient's Gaucher's is missed on the marrow. Is it possible? Manjari
Yes.
madam?
Yes, yes.
So
Nowadays,
in that
Gaucher,
case, repeating the marrow makes sense.
no.
Absolutely, you
Because
have to do. Of course,
No,
to answer
no.
that question,
Nowadays,
Subramania, I'll tell you.
Huh.
I'll tell you. One, in this child, I would definitely do a bone marrow. The reason is very simple. One, I would try to pick up gotchas. Second, I would not want to miss a malignancy.
No,
Very
these
simple.
two are fine, sir. If a
Very
bone marrow is reported normal,
No.
will you repeat?
I'll tell you one thing. For
That's what I'm
Gauchers
saying.
nowadays,
Again, let us go back to the question. It depends on if the slides are there. I will give it to my pathologist and see, rather than
Okay.
repeat it.
no, but I will tell you, Gaucher today, if you suspect Gaucher, you don't need to make a bone marrow to diagnose. Your enzyme assay is
Genetic
much
diagnosis.
better.
No, that is
Mutation
fine,
is
madam.
Yes.
No, this discussion was not about Gachar. This discussion was about getting something more from the teacher to know how you'll use your discretion in the management. Ramakrishna sir, you have been silent, please.
No, not
Your
so.
inputs on when we will take a call on repeating tests,
See,
reconsidering.
I'll be very, very selective in repeating the investigations when they are not going along with our clinical thought process. I will repeat, and I'll repeat that is which requires subject to focused examination like peripheral smear, not biochemical tests and all.
So you mean to say you will
As
do
far
the
as
test
that biochemical test is
directed
done,
by the
it
clinical
isn't
inputs.
good laboratories, right? So,
Fair enough. Fair enough. Sir, Balasubramaniam, last questions to you. Again, I'm sorry. Do you think that accreditation bodies like NABL accredited lab, if it is written, will you trust them? Or is it still that we can get NABL accreditation in spite of the lab not being good? I'm taking the discussion away, but sorry.
I think, Subramania, let us not send wrong messages to the postgraduate. I think we should not.
Okay, fair enough, sir. Fair enough.
We'll
Go back to the discussion.
here.
Don't mistake me.
No, fair enough. I got the answer. My question was, can we generalize and take something out of the discussion was my question. Otherwise, fair enough.
My answer to you, let PGs not get any wrong messages. We leave.
No, I got the point. Oh,
Thank you.
this is more an administrative
Sir, I have-
question than academic question. Fair enough. Back to
this.
Madam,
Yeah, right.
back to discussion. Yeah.
Now, your final comments. Each panelist, one sentence. Then Professor Manjari will wind up the discussion. Dr. Balasubramanian, sir, final message regarding this case in general.
Yeah, I'm requesting all the postgraduates who are attending today, please go to Harrison's textbook. Read the anatomy and physiology of spleen first, and also necessarily liver. 1, 2. Please go sit down and write causes of splenomegaly, classify them, particularly big spleen, and then write a few points for and against those diagnoses if you have a case in the exam or in your real life. Thank you.
Dr. Sarah ma'am. Professor Sarah ma'am.
Yeah.
To differentiate.
I think, yeah, same thing. Like we should try to take a proper history and come to a diagnosis, especially in these kind of cases. Like we should be able to localize the anatomy, the pathology, etiology, and come to a fairly a diagnosis with fairly good amount of certainty after excluding all the other conditions, like in this child. And also, as Sir said, we should write down all the causes of splenomegaly. That is very important for the postgraduates, because when it comes to massive splenomegaly, there are only few causes. So we won't put certain other causes in that list. So if you know that what are the causes for massive splenomegaly, then that kinds of narrows down your differentials.
So from my end, for the postgraduates, I will just give an analogy. If you take causes of vomiting, the extra intestinal causes are more common than the intestinal causes or GI causes for vomiting. I'm just taking an analogy. Therefore, when you're analyzing either the enlargement of the liver or the spleen, The causes lie outside the liver and spleen often than inside the liver and spleen. I think I've made it very simple message. Please look beyond spleen, look beyond liver. Therefore, I often see the postgraduates telling there is no history of jaundice or liver disease is out. In fact, you get less jaundice, less jaundice in a chronic liver disease than more jaundice. And please remember, so don't rule out a disease. And I'm repeating, the causes for liver or spleen often lies outside the liver and spleen. So please look beyond them. So don't go on doing anatomical tests like, for example, maybe repeat ultrasound or some CT and things like that, unless you have an obvious reason to do so. Exceptions can be in, for example, in portal hypertension and things like that. But however, often you have to make a proper revisit of the history. And most often postgraduates in the board have an advantage of having some investigations outside, which will give some kind of clue. Therefore, you need to revisit the history and ask some more questions that you would have missed in the first line. And therefore, you will often end up in making a nice diagnosis before you would draw 10 ml of sample and put 2 ml in each of these test tubes and go on sending the things. So please remember and evaluate properly. Investigation should be directed by clinical evaluation, and battery of investigation should never be done. These are some 1 or 2 messages from me. Madam, back to you.
Dr. Sara, you may stop sharing. Okay. See, I advise the postgraduates to see the broader picture. Here, if you see the broader picture, one sign is very significant, rest of the body looks very normal. There you will get some clue that you are that narrows down your diagnosis and thinking, thought process. Always do focused investigation in such cases. Don't do all investigations, which are quite unlikely. See, from the history itself, you could have ruled out infections, infestations, hemolytic anemias. Many things can be ruled out in this case because it's isolated large splenomegaly, right? Think laterally, have 360 degrees view, and you'll be on the diagnosis. Professor Manjari, madam. Dr. Piyali Bhattacharya, you are with us? Dr.
Yes,
Piyali.
I could see her.
Dr. Piyali? She has joined. Dr. Piyali Bhattacharya, you are with us? Okay.
Yes,
Yes,
he's
ma'am.
there.
Dr. Piyali, right.
Yeah, I was listening to the discussion, very nice discussion. My impression of the whole case was that I think because many a time I will agree with Subbubai that we get biased by what has been done outside. I mean, 2-3 institutions, they have looked up this patient and then the patient has come to us with certain investigations, certain history written and all that. Sometimes we fail to look beyond, and we continue to think as they were thinking instead of having an open mind. So I believe every case should be treated as a fresh case instead of going along the lines of others. And that would be actually a real opening for all of us. Thank you so much for including me.
Right, ma'am. Thank you. Professor Manjari, ma'am, your final.
Yes.
Right.
Yes, my comment, we had heard everybody and we really drawn a good clue out of that. I'm sure the postgraduates have learned a lot, but I would like to make a focused discussion on this today. What we are seeing today in our undergrad days, in our postgraduate days, rare disease, we did not focus much because there was no treatment. Now, I would say in coming 10 years down the line, the way industry is moving, the way we are getting treatment, various treatment, every day I get a call for doing a new clinical study on particular any of the rare diseases, storage disorders. So I would request everybody to keep in mind the storage disease, don't put it down the line. You please analyze the whole thing. The way we discuss the entire thing, you can analyze that if there is a massive splenomegaly, barring the few causes, maybe we will not be able to rule out HPLC being so common as Dr. Sara said, intermediate at times do present, but besides that, we should keep in mind the storage disorders, those who are having treatment. Because even in the Western world today, the delay in diagnosis is still there. Now, if you have to really give the prognostic facility and have the treatment started early, we need to diagnose. So we have to have that in our mind, the awareness, the mindedness of the rare disease should not go away from our chapter, our diagnosis, particularly this type of discussion which we had. So that is all from my side.
Professor Sarah, ma'am, shall we?
Yeah. We'll close now. I think that's.
Thank you so much.
Thank you.
Thank you, madam.
Thank you so much. Yeah.
Thank you, madam. Thank you for the nice case. And thank
Thank
you. Thank you. I think we should congratulate Sarah for taking up this case on a short
Yes,
notice.
yes.
She was
Very
confident.
short-
I mean, she was bold
very
enough to
short
present.
Yes.
So
Many people ran away when she came forward. I must personally thank Sarah for this taking up. It was
we
my
wish all
mistake,
her
but
best.
anyway.
We wish you all the
Yeah.
best, right?
Thank you,
Yes.
sir. Thank you.
Okay. Thank you. Good night.
Congratulations. Congratulations, beta. Very nice
Thank
case.
you. Thank you. Thank
Yes.
you.
Manjari madam, thank you so much from IAP
Thank
for
you.
you.
Thank you so much.
Please
Please
Thank
join
you.
us in future as well.
Yeah. Good.
Please
Yeah.
join us in future as well as a
Sure.
as a panelist. Whenever you
Sure,
are
sure.
free, please do write to us. We want to have
Yes.
more and more teachers involved. Thank you.
Sure. Okay.
Good night, all.
Bye.
Thank you.
Good night. Good night.
Thank
Good
you,
night.
Professor Manjari,
Good
ma'am.
night. Good night.
Thank
Thank
you.
you. Thank you.
Right.
Thank you
Good
so
night.
much.